Good evening, everyone. Thank you for joining us and welcome to the Sleep Better webinar with Dr. Charles Samuels. Your hosts for this session are Hydrocephalus Canada and the Association de Spina-bifida et Hydrocephalus du Québec. I'm Shauna Bodway, the Director of Programs and Information at Hydrocephalus Canada. I will be the moderator for tonight's session. So tonight we're going to focus on sleep disorders, understanding the stages of sleep, tips to fall back to sleep, and much more. Our presenter today is Dr. Charles Samuels. Dr. Samuels is a board-certified sleep physician with primary research interests focused on understanding the prevalence and effects of sleep disturbances in specialized populations. He is the medical director of the Center for Sleep and Human Performance in Calgary and a diplomat of the American Board of Sleep Medicine. Dr. Samuels is the vice president of the Canadian Sleep Society and is the chairman of the Alberta Medical Association INSOMNIA Clinical Practice Guideline Committee. He is also a clinical assistant professor of medicine and adjunct professor in the faculty of kinesiology at the University of Calgary. Dr. Samuels is regarded as an expert in the area of sleep disturbances and health consequences of shift work based on his work with the Calgary Police Service Health and Human Performance Research Initiative, which was a 10-year research project exploring the impact of rotating shift work on the health and performance of police officers. We are so pleased and privileged to have Dr. Samuels present tonight, and he's asked that we just mention some of the questions that he will be discussing tonight. One is, I need to take medication before bed. How do I deal with this if eating before bed can contribute to my sleep challenges? Another is, I developed a habit of sleeping with the radio on. How do I break this pattern of needing white noise if it isn't working for me anymore? And pain interrupts sleep. Need tips to manage this. So these are some of the questions that will be answered today in this webinar, and we would like to now welcome Dr. Samuels.
Thanks very much for the introduction, Shauna, and thanks for having me here. So I'm going to just start by doing second here. I'm being asked to do something. There we go. Just to do what I'm obliged to do as a professor at the university is just disclose any conflicts of interest. And with respect to the talk that I'm giving tonight, I have no disclosures or conflicts of interest. Basically, what you have asked me to go over is the following points of understanding the stages of sleep, and I don't consider that all that terribly important. I'm quite happy to answer questions. We're really talking about what sleep health is in the context of the science of sleep, and I will talk about that. Learning strategies to navigate sleep would be very important with regard to managing pain, which is a very complex issue and of course common in the population that we're speaking to tonight with hydrocephalus and other neurological disorders. Gaining awareness about sleep apnea was one of the questions, and of course this is something that I deal with every day, all day long, and we can do that. And then some tips and tricks on how to improve your sleep on your own, and how we actually do it in a sleep medicine center situation. So the science of sleep, how does the brain sleep, and sleep health are two of the most important things that I think we'll discuss tonight for the group, because most people really don't understand what the value of sleep is. And most of us, certainly in North America, don't really respect the importance of sleep. So the WHO now recognizes that sleep is the cornerstone of human recovery. So on a daily basis, our bodies and our brains require sleep so that our diet, our physical activity, and our mental and emotional health can actually be optimized. So as we reduce sleep or disrupt sleep, we can affect all the other things that we do in terms of gaining good health. So for instance, if we're trying to follow a good diet from a nutritional perspective, and maybe our goal is to lose some weight, but we don't get enough sleep, we will undermine our body's ability to actually lose weight. The same with physical activity, and a large portion of my research is with the Olympic teams, and with specific focus on the importance of recovery to improve performance in elite Olympic athletes. And so it's important to understand that the value of sleep is critical in improving our overall health. And that's a new concept, relatively speaking, in terms of medicine's approach to general human health, regardless of whether you have disease or not. So sleep is equivalent to physiologic recovery, which is a requirement of human performance, and both physically and cognitively. And so metabolically, energy is managed and utilized during the sleep state so that we don't gain weight, for instance. Our systemic sources of inflammation are managed during the sleep state, and our immune function recovers through the sleep state. Tissue, and from a physical perspective, tissue recovery occurs and repair. So injured individuals, pain, for instance, there's very strong relationship between sleep disturbance and sleep restriction, not getting enough sleep, and the experience of pain. So when people ask, how do I manage that? One of the things is making sure that you are sleeping, getting the right amount and the right quality of sleep. From a cognitive perspective, our memory, our mood, and our concentration are affected by the amount of sleep we get, whether our sleep is restorative, and whether we're actually sleeping at the right time for our brain. So when it comes to sleep health, the simple 3 things that I talk about with people is that you need to know the amount of sleep that you need per night and get it. You need to know the timing that's right for you. So in other words, if you're a person who's a neutral sleeper, what we would call a neutral sleeper, you usually have a bedtime of 11 and a wake up time of somewhere around 7. And that is your zone. Some people are night owls and they tend to fall asleep more easily at around 1 in the morning. And they really aren't what you would call morning people. In other words, they tend to feel better between 9 and 10 a.m., not certainly at 7 a.m. And so that would be a delayed sleep phase or a night owl. And as we age, we tend to become larks. In other words, we like to go to bed earlier and we like to wake up earlier. So that's a general concept. And so you need to sleep when it's best for you, and you need to maintain a routine so that the brain remains quite stable. And this is usually what people are doing to disrupt their sleep. They're really not sleeping in a routine day to day and then weekday to weekend. Quality of sleep is really ensuring that the sleep you get is restorative. So if you're someone who gets 8 hours of sleep a night, but you wake up unrested every day, this is a concern. And that is not a good quality of sleep, and it should be looked into. So the 2 most common sleep disorders that we see and would be common in your population of individuals would be insomnia and obstructive sleep apnea. There are many other disorders. I'm happy to answer questions at the end about them, but I'm going to go over these 2 disorders because they're the most common. And insomnia, by definition, is difficulty falling asleep and difficulty staying asleep, or both together. And the way that it would present as a syndrome is one of difficulty falling or staying asleep with daytime consequences. In other words, do you have insomnia that affects how you feel during the day or how you perform during the day? That would be considered the insomnia syndrome. And that is what we call clinically significant. It requires a healthcare professional to assist you with. So when you have insomnia of that nature and you go off to the pharmacy to get an over-the-counter sleep aid, we would argue that that's not the best approach. It would be better to go to your healthcare professional and discuss the problem with them to get a good approach, not just medication, because we don't really advocate the use of medication for insomnia without an assessment. However, the more prevalent concern is one of insomnia symptoms, people who complain of difficulty with sleep, but don't have any daytime consequences. We don't consider that clinically significant, requiring a healthcare professional, but that is a situation where a person needs reassurance and some help with their sleep behaviors to improve their sleep overall, but it's not affecting their daytime functioning. So the consequences that we see in individuals who have, again, what we call clinically significant insomnia, in terms of symptoms that they would complain of, would be irritability, impaired concentration and memory, chronic daytime fatigue. Their behavior changes, they become quick to respond and irritable. They feel hyper aroused, and that is the underlying physiology of insomnia. It's a state of being really aroused or awake or sometimes anxious, and you can't calm down to let the brain take over and enter into a sleep state. Appetite changes occur with insomnia and can go in two directions, either a higher appetite, where you tend to want higher calorie dense foods, or a loss of appetite. So it can go either way. So the signs of insomnia would be, as I've said, quick tempered with the family. Often we'll see patients, mom or dad would say, you know, I no longer have patience with the kids at the end of the day. I'm just so tired. Poor focus and attention at work, low energy and motivation to be active, let's say, and go for a walk with the dog at the end of the day. Tend to be agitated, and the mood is somewhat fragile. And the classic description of an insomniac would be tired but wired. In other words, fatigued with low motivation, but feeling really agitated and quite aroused. And then again, the negative consequence from an appetite perspective would be a high appetite for high calorie dense foods. In other words, high fat content foods and high carbohydrate content foods. So the way we make the diagnosis of this syndrome and its prevalence is really 6 to 10% in the population. And this is from research done at Laval University from actually a world-renowned insomnia researcher. And this is important because this 6 to 10% represents those individuals who really do need to see a doctor, whereas the complaint of insomnia is almost 30 to 50% in the population from StatsCan data done in the public health surveys. So clinically significant insomnia would be 3 times a week for more than 3 months. That's our sort of definition. And then the same would be the case for those people complaining of symptoms. It's just, and when it's clinically significant, it is associated with medical and psychiatric comorbidity, which would be other conditions. So when you have insomnia with daytime consequences and you have a reduced total sleep time at night, you have a higher incidence of having cardiovascular and metabolic disease, so high blood pressure and diabetes, and also a worsening of psychiatric illness or the risk of developing psychiatric illness as a result of chronic insomnia. So this is important. It needs to be detected by a healthcare professional, and it requires treatment and monitoring. If you're simply symptomatic with insomnia, it should resolve without any intervention, and it simply requires reassurance and discussions around what we call sleep hygiene. In other words, what's your sleeping environment like? Do you maintain a routine? And are you careful to limit your coffee consumption, let's say late in the day? If you're a smoker, limiting your smoking at the end of the day, because nicotine is quite a stimulant to the cortex of the brain and can actually seriously affect your ability to sleep through the night. So the pathophysiology is one of really a high state of arousal. So in other words, physiologically, we detect when we're studying people an increase in the core body temperature, an elevated basal heart rate, changes in the sleep-wake regulatory mechanism. And then we can see in the brain when we put people into the sleep lab, arousal in the brain actually from the EEG. External triggers that disturb sleep, so not internal factors, would be pain, as has been mentioned earlier. Personality traits, are you predisposed to insomnia? So I saw a patient today who is in his 60s and recalls that his mother was on Valium in the 1970s as a result of having insomnia similar to his today. Mood and anxiety can affect sleep. Medical conditions such as hydrocephalus and other conditions, neurological conditions, can affect sleep. And then comorbid sleep disorders. So there, for instance, is an overlap between insomnia and obstructive sleep apnea. And obstructive sleep apnea in a patient who has insomnia can certainly disturb their insomnia significantly. Psychological factors that affect insomnia would be personality traits. So do you tend to be, for instance, a type A individual? Those individuals have a higher prevalence of having clinically significant insomnia. And are you genetically predisposed? Because we know there is a genetic predisposition to insomnia. You could have a precipitating event that would be either a stressor, for instance, let's say a motor vehicle accident or a loss of a family member that would precipitate the insomnia. And then you would develop perpetuating behaviors. So the classic one would be when you have insomnia and you are fatigued during the day, the tendency would be to increase your coffee consumption, which worsens your sleep. The other is that you develop cognitions, which is basically fear around not being able to sleep, which makes the insomnia worse. So the health consequences, as I've said earlier, insomnia with a short total sleep time. In other words, if you have insomnia and you get less than 6 hours of sleep per night, you are at higher risk for having hypertension, cardiovascular disease, poor weight control, metabolic dysregulation, which would be basically diabetes. You're at higher risk for having injuries in work, and you're more likely to be disabled from your work. Psychological and psychiatric consequences would simply be behavior, affecting your behavior, impaired concentration and memory, which would affect your productivity, chronic fatigue, high states of anxiety, and then possibly even depression. So the treatment options when it comes to insomnia are quite clear. There's good research to support the various treatments that we go through. I won't go through this in detail, but the bottom line is that our core treatment for insomnia is behavioral therapy, and it is cognitive behavioral therapy for insomnia. So here at the Center for Sleep, we have 4 full-time behavioral sleep medicine specialists seeing patients all day long. So in other words, this is a very busy part of our practice. And these people are very highly trained, and they go through various behavioral techniques. And I'll give you resources to explore this on your own to help the patients. And they'll see the patients once every 4 to 6 weeks for about 45 minutes over a period of 6 to 9 months, in the hopes that this can control the insomnia, get them back to a normal state of sleep without medication. The doctor's role is to use medication in combination with the behavioral sleep medicine specialist. The most significant and effective way to improve insomnia, so for those of you that are listening and struggle with falling asleep and staying asleep, is to actually restrict the sleep time. So in other words, most patients with insomnia tend to lie in bed longer than they need to. And we will have them go to bed later and get up earlier to improve the depth and the quality of their sleep, rather than just have them lying in bed trying to sleep. So there are many online sleep applications, and I'm giving you a list of them in the slides, which I think you have access to. And it's important to understand that there are benefits and downsides of these online resources. I think in a complicated population, which would be this population I'm speaking to today, my tendency would be that if you have sleep difficulty, you really should be talking to your doctor. You can try some of these things on your own, but if they don't work, don't get discouraged, because there are many things that we can do. But generally speaking, the benefits from a research perspective of these online tools is actually marginal. And here are the reasons why. So there are disadvantages to these online tools because they basically, the lack of adherence is high by patients using them. They're overgeneralized. There's no therapist involved. And what we do know is that one-on-one or group therapy with a proper therapist makes a significant difference in the effectiveness of these interventions. There can be technical issues, of course, just like we had earlier. And there are, of course, privacy concerns. But again, patients who choose to use these things should be aware of that and decide on their own whether they want to take those privacy risks. The advantages are that it's accessible. They're using really interesting advanced algorithms to help the patient. So it's interesting. Sometimes there is instant support call-in to professionals, nurses and whatnot that serve the app. But again, the cost of that app will go up with the services provided. And it's using newer creative gamification to try and achieve a health outcome. So I'm just going to go through these quickly. You can, of course, investigate this. Probably the one program that we've used the most, but unfortunately is no longer available, is Sleep.io. And you can go and see it, but I have a feeling it's no longer available to the public. It's used through insurance companies now, mostly. These are also other services, the CBTI web org, which is an 8-hour workshop. Then there's David Gardner from Dalhousie. This is a very good program. It's available to you online. And my understanding is that it actually is free. So this is, and it includes a tapering of sleeping pill guide and planner, which is really helpful. So this would be one that I would recommend for people's use as well. All of these other ones they're different. There are costs associated with them. I have to say that Dr. Judith Davidson is a very reliable clinician in Canada and has written the book that we recommend the most, which is Sink into Sleep. So anything she's involved in, I would argue, is probably really quite effective and good. Dr. Greg Jacobs is from Harvard, and he's been around from the beginning of time, basically, and his programs are really well tested and quite effective. These are just some more. But I would strongly urge you to consider Sink into Sleep if you're interested in self-help books, because this is very good. It's an excellent resource. We also use the Insomnia workbook by Stephanie Silverman. So these are really reliable resources to help you with on your own if you're not seeking a healthcare professional or going to a sleep clinic. Sleep apnea and sleep disordered breathing, that's what we refer to, is a complex sleep-related breathing disorder and is more complex in patients with neurological disease. I'm going to basically give you the simple snapshot of what it is. But the bottom line is it's associated with snoring, stopping breathing in the middle of the night, associated with choking and gasping, and usually quite restless sleep with leg kicking and lots of movement. There's a lot of sweating at night. You can have to go to the bathroom quite frequently. And there can also be gastroesophageal reflux associated with it. But the one symptom that individuals have most is awakening with heart racing and palpitations. What they'll tell you, the patients who experience obstructive sleep apnea as opposed to central sleep apnea, is that their sleep is disturbed and non-restorative. They experience maintenance insomnia. In other words, they have no difficulty falling asleep, but they have difficulty staying asleep. They tend to be irritable. And the number one symptom that's most concerning is excessive daytime sleepiness. In other words, they have difficulty staying awake during the day, so much so that it's a danger with driving. And this is a concern from a safety perspective. Their concentration and memory is often impaired. And again, they also have behavioral changes, irritability, and depression. So when patients present with symptoms of sleep apnea, the bottom line is that they need to pursue testing. And so depending on where you are in the country, testing, the availability of testing is very different. So it's not uniform across Canada. In other words, if you're a patient with chest pain and possible cardiac disease, you can be referred for a stress test in all provinces fairly similarly. However, when it comes to sleep medicine, it's different across the country. So level 3 home testing is very available in some provinces and not available in others. For instance, in Ontario, there is no level 3 home testing because you have sleep labs, but your wait list for the sleep labs is of course quite long. In Alberta, we have very few sleep labs and a lot of level 3 testing, but those are distributed by companies that have a vested interest in selling you treatment, for instance, CPAP therapy. So there's a conflict of interest there. So each province is very different and there's a spectrum of availability. So you need to rely on your family doctor or your primary care provider to help you make the decisions about which way to go. But testing is necessary to determine whether you have sleep apnea, how bad it is, and whether you need to be treated with either CPAP therapy or some other therapy. Okay. So home sleep testing, basically you should be aware that there are limitations to the usefulness of this technology, which is quite limited and not like a sleep lab, but it's easily accessible in some provinces. And so basically, if you have a complicated medical history, home testing is really not the way to go. You should really be seen by a sleep specialist and then sent to the sleep lab. And so home testing is really good for those patients who have no other complicating medical features, other diseases or insomnia or other sleep disorders, because the home sleep test is limited in its ability to detect apnea in patients who are otherwise more complicated. Treatment, the sort of standard treatment for obstructive sleep apnea would be CPAP therapy, which is continuous positive airway pressure, or auto-PAP. And this is available in all the provinces. Again, covered in some provinces, not covered in other provinces, so it makes it difficult. And the technique in this treatment is to keep the airway open using positive airway pressure. So the individual is sleeping with a mask at night. Some of you may have partners who use this. You may use it yourself. And so it's an odd kind of treatment, but very effective. Other techniques are bi-level treatment therapies, which are more complicated and used in more complicated patients. Oral appliance therapy has now come into its own as a very effective treatment for sleep apnea in the mild to moderate range. And then there are surgical procedures, either ENT surgery or maxillofacial surgery. So we recommend all of these strategies for patients depending on how severe their apnea is. We will go through all the options with them and refer to the appropriate provider. So other techniques are new and unique. I'm not really going to go into those. The conservative measures are very important. So in other words, weight reduction is critical. Positional control, because sleep apnea tends to be worse when someone is sleeping on their back. And then reducing alcohol consumption at night, smoking, and sedatives or muscle relaxants all worsen sleep apnea, which might be the case in patients with spina bifida who have muscle tension or chronic pain. they're using drugs to manage the pain that might actually be making sleep apnea worse. And I can discuss that in more detail. So that's the bulk of what I wanted to talk about. And we have at least 20 minutes left, and I'm quite happy to answer questions because I think more comes out of the questions than anything else. So I'm going to turn it over to Shauna to just help me out.
Sure. So one of the first questions we had, Dr. Samuels, and thank you so much for that presentation. What do you do when you get night sweats, and it interrupts your sleep?
So, I mean, it depends on the cause of night sweats, because night sweats can be indicative of many things, including cancer. So it has to be sorted out with your family doctor. So with respect to the things that I'm talking about tonight, if one of the biggest ones in women, of course, is menopause. So in other words, that doesn't have anything to do with sleep apnea necessarily. Although, interestingly enough, the prevalence of sleep apnea increases in women in the menopausal years for a host of very important reasons. So women tend to have less sleep apnea under the age of 50 and more after, largely due to menopause, because it changes the integrity of the tissue in the upper airway and makes it more susceptible to collapse. So sweating occurs when the airway closes and the heart rate increases in an attempt to compensate for loss of oxygen. And then when the person starts breathing again, the heart rate escalates, and then they have basically a surge of adrenaline, which causes the sweating. So if the sweating is due to apnea, it's because of the obstructed airway, but it could be because of menopause, or many other things can cause sweating at night.
Okay, great. Thank you. The second question is, what for people that need to take medication before bed, but they have to eat something before it, can that contribute to sleep challenges?
Not really, no.
No?
I think the amount that you eat when you're taking a medication is so small that it would make no difference to sleep.
Okay, and you mentioned positional control. What does that entail, and how do you keep someone from rolling onto their back once they are asleep?
That's a very good, well, short of punching them every time they choke and gasp, which of course, you know, men will come in and go, well, I'd sleep fine if my wife would stop punching me, you know, but this is not an effective way to keep them on his side. So what I will tell patients, so we'll do a sleep study, we'll see that when they're supine, which is on their back, they tend to have apnea, but when they're on their side, they're fine. So one of the treatments is actually, and this is my approach to this, you know, people will use tennis balls and all kinds of weird stuff, but really it's to buy a foam wedge, a 30-degree foam wedge, the full length of the individual's torso. And they just sleep on that. It's comfortable, it keeps them on their side, and then they don't snore or stop breathing.
So even like a body pillow would be helpful then in
Sure.
that instance.
Yeah, you bet.
Okay. Okay, next question is, I've developed a habit of sleeping with the radio on. How do I break this pattern of needing white noise if it isn't working for me anymore?
Well, first of all, if it's not working, it's not, you don't really have to break the habit, you just stop it. I would have argued that white noise is actually not a bad thing. So in other words, maybe it's just switching from a radio to something else, white noise, if it works. But if the person is saying it no longer works, this is my point, is that at the point where the things you're trying aren't working, you really should go to your doctor and get properly evaluated. This is something for a medical doctor or a healthcare professional, whatever kind. It could be your naturopath or your chiropractor to address with them, and they'll give you strategies and possibly refer you to a sleep clinic like ours where you're going to get proper care.
Okay. Next question from someone on the session today. It says, does methotrexate make breathing more difficult?
No.
Okay. Okay. Next question. I have been waking up at 2 a.m. Very scary how close to 2 a.m. no matter when I go to bed. What could the reason for this be?
Yeah, so that's a really good question, and I often will cover that question when I'm speaking to doctors. because that's actually related to sleep stages. So the reason you wake up at night at the exact same time every night, which will be ubiquitous across all people, is that you go and your sleep stages change every 90 to 120 minutes. You go through cycles. And at the end of a dream cycle, your brain will be susceptible to awakening. And so at 2 a.m., generally speaking, you've finished 2 cycles of sleep and you've actually gotten your deep restful sleep, and you'll be more susceptible to waking up. Regardless of when you go to bed, it'll be an entrained pattern. And this is actually what the behavioral sleep medicine program is designed to do, is to break those patterns.
Okay. My next question, how do you manage when pain interrupts your sleep?
Yeah, so this is very difficult, the relationship of pain to sleep. So, I mean, I don't think I could answer that question on this, in this setting. But the bottom line for people to know is that pain and sleep are linked. What we do in our setting is have the patients with chronic pain see the behavioral sleep medicine specialist, one, to help them learn about how to sleep better and deeper so the pain doesn't wake them, and 2, to give them strategies for mitigating the effect of pain on sleep. In other words, reducing the state of arousal associated with pain when you wake up in the middle of the night. From a doctor's perspective, we would focus on pain control.
Sleeping with meditation, is that good?
Absolutely. Yeah, it's a core part of what we do with patients, is teach them meditative breathing. So breathing techniques, meditation, and then mindfulness are very much a core part of the behavioral sleep medicine program. Absolutely.
Okay. Next question. I have to wake up to use the bathroom multiple times per night. I restrict fluids after supper. My guess is it's just the legs being elevated and my body removing the fluid from the body. Anything else I can do to make the sleep time bathroom visits less frequent?
So I think when it comes to having to go to the bathroom in the middle of the night, obviously limiting fluid consumption close to bedtime is a simple thing that can be done. It may or may not work. When people are going to the bathroom frequently in the middle of the night, one question you have to ask is, are they sleeping well? Because often if they're going to the bathroom, but it's small volume, it's not actually going to the bathroom that's causing the awakening. It's that they're not sleeping deeply. So the focus would be on sleep. If they have large volumes, then there's too much drinking going on and they're peeing more because they have too much fluid in them. As far as lying down, yeah, that's true. But if your renal function is normal, you should be able to maintain a balance by not over drinking at the end of the day. So it's a tough balance. Frequent urination at night is more an indication that there's something else going on.
So there's another question related to the meditation.
Okay.
It appears that they wake up even if they do the meditation. Is it because they go to bed too early?
Well, I mean, again, I'd have to speak to the individual to get a sense of what's going on. But the bottom line is that it's more than just meditation. One is routine. And going to bed later is always better for individuals with insomnia. That's universal. So whatever the bedtime is, I usually will say an hour later, at least, depending on the bedtime. So that's one, because it helps to deepen the sleep, and then using the meditation techniques when they wake up to get themselves back into sleep would be what we would recommend.
Okay. So many people with spina bifida have insensate skin, and we don't often feel pain, but it wakes us up.
Right.
So how would you manage that?
Yeah, so it's always about deepening the sleep state, because that's a complicated question. It's a really good question, because the assumption would be, well, you don't feel it, so why would it wake you? But that's not true. It can. And so in that case, we're really talking about deepening the sleep state so that mitigates your response. And then also looking for triggers. So another would be, which I suspect is fairly common, is sleep apnea and snoring, which is completely ignored probably in this population. And it could be very significant.
Okay, it's good to know. A question about trazodone.
Trazodone, yeah.
Is it good to help my sleeping, like falling asleep faster during the night?
Yeah, so trazodone is used as a Valium type drug for sleep, and it really is very good in the right population. We use actually a lot of trazodone, and we use it again to achieve a deeper state of sleep in very hyper aroused individuals, which would include chronic pain. And for instance, in a psychiatric population, I deal with a lot of PTSD from the military and law enforcement. And so we use trazodone. So it's actually a really good drug, and it's often not dosed high enough. So if a person is on 50 milligrams, sort of better, but not fully better, we will push the dose to 100 to 150 milligrams, and it can work quite effectively.
Can any of the pharmaceutical sleep aids become addictive?
Yeah, so this is a controversial comment, but the fact is that none of the sleep aids available, for instance, in Canada, are addictive by definition. You can definitely become dependent to them, and you can definitely become tolerant to them, which means you would be increasing the dose, but addictive, very rare.
Okay, and I think we have one last question here. I find no matter what my sleep routine is, I'm always worse when I sleep nap rather than if I don't. 9 out of 10 times I wake up with a headache, and I'm usually up late on my computer. So I guess the question is the computer causing the sleep issues, or is it the person's condition, such as hydrocephalus, that is not letting her shut down?
No, not at all. The hydrocephalus doesn't cause this high state of arousal. Sitting in front of a computer is the biggest problem we have in the world today with regard to sleep health. So technology is disastrous with regard to sleep health. And so this person's experience of, I think she said napping during the day, definitely. I missed that. But napping will definitely be destructive to nighttime sleep. And the computer up to bedtime, a terribly bad habit. So I understand that people do it and they think they need to do it, or that's the only thing they can do, but it's very bad for sleep.
So you're saying we should turn off all of our electronics at least 15 minutes before we go to bed, or even longer?
So 6 p.m. So
oh my gosh,
I'm bad. Yeah. Because when people come here, they're desperate. And if they want help, they have to turn the computer off because their entire life is on the computer. And that is an extremely unhealthy human behavior. And I know that from the highest levels. I've worked for Red Bull Video Gaming for 2 years with video gamers who make over $1 million a year gaming. And I can tell you that at that level, these kids are suffering. The computer is terrible, absolutely terrible for sleep.
I 100% agree, but it's very hard to break that habit.
Exactly. Yeah.
We have one more question about melatonin. Would it be recommended for sleep problems?
No. So melatonin is useful for circadian rhythm disorders and for shift work. So in other words, night owls, we use it very specifically to help them fall asleep earlier, but we use that in combination with light therapy, which is the winter depression light that we use to stabilize the sleep-wake cycle. But using it just randomly for insomnia, it actually doesn't work.
Okay, good to know, because I'm sure a lot of us
many people
try melatonin.
Yeah.
Okay, well, I think that wraps it up for us. Thank you so much. This was very informative.
My pleasure.
Actually, I did have one additional question.
Mhm.
Do you have on your website, do you have a list of sleep clinics or
Canadian Sleep Society.
Canadian
have a
Sleep
map.
Society?
Yeah,
Okay,
if you
perfect.
go to their website, they have a map of sleep clinics all over the country.
Perfect.
All
Okay,
right.
Canadian Sleep Society. We will get that out to everyone.
All
Thanks
right.
again very
Take
much.
care.
We
Have a good night.
appreciate it, and thanks again.
You bet.
Lovely
Take care.
presentation. Okay,
Yeah.
bye
Bye-bye.
everyone.